Assalamualaikum warahmatullahi wabarakatuh, and hello everyone. Thank you for joining our CME today. Now we are going to discuss regarding control of breathing. This is my first video presentation. Hopefully all of you can see my handwriting clearly and can hear my voice very well. So let's get started. Regarding control of breathing, we have two control of breathing. We have involuntary and voluntary. So involuntary control, we have four components, which are respiratory center or brainstem. We have a chemoreceptor, we have mechanoreceptor, and others. Whereas voluntary control, it is mainly controlled by the cerebral cortex. And then we also have to know that cerebral cortex can override involuntary control temporarily. So regarding the respiratory center at brainstem, it involves medulla oblongata. It has two components, which are DRG or dorsal respiratory groups. It also known as inspiratory center. And then next is VRG or ventral respiratory groups. It is also known as expiratory center. Next, we move on to PONS or PRG or pontine respiratory group. It has two components, pneumotaxic center and apneustic center. We move on to chemoreceptor. Chemoreceptor has two components also. We have central chemoreceptor, which also involve at the level of brainstem, and peripheral chemoreceptor, which are located at carotid bodies and aortic bodies. Next, we move on to mechanoreceptor. We have four mechanoreceptor in our body. We have lung stretch receptors, joint and muscle receptors, irritant receptors, and J receptors. Other component of involuntary control of breathing, we have respiratory muscle. There are three main components: internal intercostal muscle, external intercostal muscle, and diaphragm. And lastly, we have pain, emotional, and hormonal changes, which involve hypothalamus. Alright. So this is a diagram of brainstem. At the pons level, pneumotaxic center located at the upper parts of the pons, and then apneustic center located at the lower parts of the pons. And then ventral respiratory group or VRG located at the ventral aspect or anterior aspect of the brainstem, whereas the dorsal respiratory group or DRG located more posterior or dorsal aspect of the brainstem. And we have to remember that both groups or center actually come in groups. Actually come in pair, which are bilaterally right side and left side of the brainstem. So regarding DRG and VRG, DRG responsible to set and maintain the rate of respiration. So DRG is our fundamental control of breathing in our body. It will receive input from peripheral chemoreceptor and mechanoreceptor, and next it will send motor output to diaphragm via phrenic nerve. Whereas the VRG or expiratory center, most of the time it is inactive in quiet and restful breathing, but it can be activated in forceful breathing or during an exercise. Regarding the pontine respiratory group, pneumotaxic center and apneustic center is antagonistic towards each other. So pneumotaxic center, it will send inhibitory impulse to inspiratory center. It has a term as IOS or inspiratory off switch. So what happen is it will limit the burst of action potential in phrenic nerve, and then subsequently it will decrease the tidal volume and regulate respiratory rate. So when a faster rate of breathing is needed, pneumotaxic center signals the DRG to speed up the breathing. So at apneustic center, what happen? It will produce abnormal breathing pattern during inhalation. So the pattern is it will prolong the inspiratory movement, and then it will followed by a brief expiratory movement. Apneustic center will send signal to the DRG, it will delay the IOS, and then it will subsequently control the intensity of breathing. Apneustic center can also send inhibitory impulse to the pneumothoracic center, and it also can be inhibited by pneumothoracic center or pulmonary stage receptor. Okay, next we move on to chemoreceptor. We have central and peripheral chemoreceptor. Central chemoreceptor located at the ventral aspect of the medulla oblongata. It will communicate directly with DRG, and it is very sensitive to changes in pH of CSF. So what happens when pH in CSF is acidic? It will stimulate hyperventilation. Why? If pH in CSF is alkalosis, it will stimulate hypoventilation. Central chemoreceptor indirectly respond to the changes in arterial partial pressure of the carbon dioxide, and then it responsible to keep the arterial PCO2 within normal range. Whereas the peripheral chemoreceptor can be stimulated by three stimuli: oxygen, carbon dioxide, and hydrogen ion. And then peripheral chemoreceptor located at the keratotic bodies and iotic bodies. Okay, this is a diagram at the level of capillary, medulla, and CSF. So carbon dioxide is permeable across the brain CSF barrier and enter CSF, but hydrogen ion cannot cross blood-brain barrier and blood CSF barrier. So what happens is when arterial partial pressure of the CO2 increase, and then subsequently it will increase the partial pressure of the CO2 in brain and CSF, and then the pH in CSF will become acidic, and then central chemoreceptor will detect the pH of acidosis in CSF, and then as a result it will instruct the DRG to increase the breathing rate. And then what happens next is more CO2 will be expired, and arterial PCO2 will decrease towards normal. Okay, this is a diagram of the peripheral chemoreceptor. We can see here keratotic body and iotic body. Okay, so regarding peripheral chemoreceptor, peripheral chemoreceptor will detect arterial partial pressure of the oxygen if less than 60 millimeter mercury. It will respond dramatically, but if partial pressure of the oxygen more than 60, it is relatively insensitive. Okay, so what happens is when partial pressure of the oxygen in arterial less than 60, it will cause breathing rate increases by stimulating inspiratory center, and then it will rectify the lack of oxygen. But in cases of increased arterial partial pressure of the CO2, it is actually less important than detection changes in PCO2 by central chemoreceptor. In case of low arterial pH or acidosis, it is only mediated by chemoreceptor in keratotic bodies, and it will cause increase in ventilation as a compensatory mechanism of metabolic acidosis. So next we are going to discuss regarding the mechanoreceptor. Okay, we have lung stretch receptor, can be found in smooth muscle of the airway. So what happens is when distension of lung happens, it will initiate the Herring-Brewer reflex. So Herring-Brewer reflex, it is a mechanism, or it is a reflex to prevent overinflation of lung, and it will decrease in breathing rate by prolonging expiratory time. So second mechanoreceptor at the joint and muscle receptor, it will detect movement of the limb during exercise, and then it will instruct inspiratory center to increase the breathing rate. So it is actually for early anticipatory or ventilatory response to exercise. Okay, next, irritant receptor. It is located between epithelial cell lining the airway, and then what happen is it will cause constriction of bronchial smooth muscle, and subsequently it will cause increase in breathing rate. Okay, so lastly we have J receptor juxtacapillary. It is located in alveolar walls near the capillaries, and then in cases of, for example, left-sided heart failure, it will cause engorgement of pulmonary arteries and increase interstitial fluid volume. So as a result, it will cause increase in breathing rate. So what happens in left-sided heart failure? When blood backs back up in pulmonary circulation, it will stimulate the J receptor, and then it will change the breathing pattern, and then next it will cause the patient to turn into rapid shallow breathing and also difficulty in breathing. Alright, so I think that's the end of my presentation. Hopefully all of you can understand the explanation and then can remember. So see you again in next video. Hopefully you can enjoy our CME, and then that's all for now. Thank you and bye bye. Assalamualaikum warahmatullahi wabarakatuh.